and life sciences are among the priority areas for the Newton Fund in the Philippines. In this session, we have invited specialists who will talk about how the Newton grants help in achieving sustainable development goals and the role of their universities in research and and its practical impact to the community setting. Our first speaker this afternoon is Dr. Paulo Silva, a staff ophthalmologist and chief of telemedicine at the BITAM Eye Institute of the Joslin Diabetes Center. He is also assistant professor of ophthalmology at the Harvard Medical School. Dr. Silva's work is on innovative and investigative work on clinical care and technology with the aim to provide an ideal model for the delivery of evidence-based and efficient diabetes eye care. Next speaker.
Hi, Lisa.
Yes. Hello.
Hi. Maganda yung reception nila.
May we request all participants to keep their mics muted in the meantime. And if you have any questions, do feel free to pop them on the chat. Our second speaker is Professor Charles Yu, who is an expert on tuberculosis, particularly on public-private mix, DOTS PPMD. He is Vice Chancellor for Research in the De La Salle Medical and Health Science Institute. Dr. Yu also served as a member of the WHO DOTS Expansion Committee and President of the Global Alliance for TB Drug Development Stakeholders Association. Finally, our third speaker this afternoon is Dr. Lourdes Bernadette Tipi Tanchanco. She is an associate professor and director for research and innovation at the Ateneo School of Medicine and Public Health. Dr. Tipi is also a clinical director and consultant of developmental behavioral pediatrician at the MedMom Institute for Human Development at the Medical City. So call on our first speaker, Dr. Paulo. Please proceed.
Good afternoon. So let me queue up my slides. Thank you to the organizers of the symposium. I will be presenting some of the exciting progress that we have achieved despite the limitations imposed by the current pandemic. Through the support of the Newton Agham program, our work has begun to change the landscape of diabetic retinopathy screening. I'd like to start by sharing some information on REACH-DR. The project is funded by a Newton Agham grant jointly to Professor Tunde Peto of Queen's University, Belfast, and myself on behalf of the Philippine Eye Research Institute. The project seeks to establish a DR screening program in the Philippines. The future of retinal imaging for diabetic retinopathy screening should start to move away from tertiary medical centers. Telemedicine diabetic retinopathy screening programs have the potential to be deployed in a wide geographic area and access a diverse patient population. This can be achieved by using less expensive but more convenient medical imaging devices. Provides also an opportunity for broader accessibility of imaging and improved portability of imaging devices together with increased patient participation in surveillance. Mobile, handheld, ultra-portable retinal imaging devices offer a unique solution to address these needs. Through our study, We performed a standardized diagnostic evaluation for diabetic retinopathy of multiple handheld imaging devices available in the Philippines. These were compared with gold standard retinal imaging used in the clinical care of the patient. This was a prospective, multi-device validation study. All images were acquired by clinical trial certified photographers. All images were evaluated at a centralized reading center using identical color-calibrated high-definition displays in a standardized display format by trained retinal graders. All discrepancies were adjudicated by a senior retina specialist. The Early Treatment Diabetic Retinopathy Study, or ETDRS 7-field 30-degree photography, has long been the gold standard for determining the rates of diabetic retinopathy severity and progression in both clinical and research settings. It has been used to establish our current guidelines for follow-up and treatment of diabetic retinal disease. We compared ETDRS 7-field photography with images taken with handheld imaging devices. As you can see, the extent of the retina imaged using 3 imaging devices are similar to the ETDRS 7 fields. Based on the study results, images acquired with the Aurora and RV700 meet current guidelines for diabetic retinopathy screening programs, achieving a sensitivity and specificity of over 80% and 95% respectively for any DR and referable diabetic retinopathy. One of the most important aspects that would support wide-scale adoption is to determine cost effectiveness. In collaboration with the Department of Health, a decision analytic model was developed to simulate the cost and outcomes of each device. The key measures of effectiveness were determined by the device's operating characteristics, including positive and negative predictive values, as well as the rate of ungradable images. Associated cost of screening, referrals, laser treatment, and severe visual loss were estimated. Health outcomes were reported as quality adjusted life years, or QALYs. The main outcome measure is reported as cost in Philippine pesos per QALY gained. This table shows the cost effectiveness analysis. The use of the Aurora with Midriasic was the most cost effective with an incremental cost effectiveness ratio of 146,000 pesos per QALY gained. The results of this cost effectiveness study showed that the use of handheld retinal imaging with pupillary dilation yield good value for money, and the reported ICER value falls below the Philippine-specific threshold of 150,000 pesos. This emphasizes the potential for being cost-effective in a community-based diabetic retinopathy screening program. In summary, the observed DR grading agreement between handheld imaging and ETDRS photography suggests that handheld retinal imaging performed and evaluated in the protocols described may be accurate for DR screening programs. The size, cost effectiveness, ease of use attributes would allow them to be widely deployed in a community-based DR screening program. Based on these outcomes on handheld retinal imaging, we proceeded to perform a community-based diabetic retinopathy screening. On the first year, we evaluated the cross-sectional rate of diabetic retinopathy in our target population in Region 3 in the Philippines. We sought to compare the rates of referable retinopathy, identified in a prior rapid assessment of avoidable blindness and diabetic retinopathy, or RAB plus DR, with the ongoing community-based DR screening program in the same population. The RAB plus DR was performed in August to October 2017 in preparation for the implementation of the diabetic retinopathy screening program. The RAB plus DR followed a standardized methodology using a random compact segment sampling with addition of ultra-wide field imaging to assess diabetic retinopathy and diabetic macular edema. The DRSP was performed using a validated method of 5-field 50-degree mydriatic retinal imaging using handheld retinal imaging devices, as I have described earlier. This protocol has been shown to have substantial levels of agreement for retinopathy and macular edema compared to the gold standard. The current DRSP is ongoing, and the data presented was collected during the COVID pandemic when lockdown was released between February to March 2021 and June to July 2021 for a total of approximately 12 weeks. Currently, we have imaged over 1,800 patients, or more than 30% of the screening target. The RAB plus DR and the community-based DR screening program sequentially evaluate the same target population. Although there are differences in the study methodology, with the RAB-DR evaluating the causes of visual loss in the population over 50, and the DR screening program evaluating only patients with an established diagnosis of diabetes. The characteristics of the two cohorts were not substantially different. This table shows the prevalence of diabetic retinal disease in the RAB plus DR and the DR screening program, evaluating the same target population. A total of 1,609 individuals were evaluated in the RAB plus DR, with 21.2% of individuals with diabetes. DR severity based on ultra-wide field imaging was 70.1% no DR, 11.1% mild NPDR, 10.3% moderate, 2.9% severe, 5.6% PDR, 7.4% with DME, and 2.4% were ungradable. The diabetic retinopathy screening program evaluated 1,174 persons with diabetes. The distribution of diabetic retinopathy severity was 68.8% no DR, 15.2% mild NPDR, 8.9% moderate, 6.4% severe, 11.7% PDR, 16.9% with DME, and 5.5% were ungradable. Referable diabetic retinopathy was defined as moderate NPDR or worse, any DME, or ungradable images. Referable DR was identified in 18.7% of the RAB plus DR cohort and in 32% of the diabetic retinopathy screening program. In our first year of screening, there was an over 100% increase in the cases of vision-threatening retinopathy in the community-based diabetic retinopathy screening program cohort. The conduct of the study was limited by the COVID-19 pandemic. The data presented represent only 23.5% of the target, with the screening still ongoing. Furthermore, the COVID-19 pandemic restrictions may have impacted our ability to fully assess DR in the population. Similarly, the pandemic has affected the patient's ability to receive diabetes eye care, resulting in more severe disease being identified. In this cohort, there is a significant first pass effect that is observed. The first pass effect is a recognized finding in newly established DR screening programs. However, prior reports have not been able to fully quantify its magnitude. The availability of a baseline RAB plus DR study that was performed in preparation for the diabetic retinopathy screening program in the same population allows direct comparisons and suggests a 71% increase in referable disease with an over 100% increase in vision-threatening disease in that same cohort. To conclude, in the initial year of screening, there will be a significant first pass effect. detecting higher levels of previously undetected prevalent disease. Due to this first pass effect, the planning of diabetic retinopathy screening programs needs to account for this initially large demand placed on eye care services. In our cohort, there is a 71% increase in the rate of referable diabetic retinopathy that will need to be accommodated in the existing healthcare system. With increasing retinal imaging, there will be an accompanying growth in the number of images that need to be evaluated. Systematic evaluation of all patients with diabetes increases its cost effectiveness. All images acquired rely on a standardized retinal evaluation. Thus, over the next 2 decades, there is a need to address over 1.3 billion retinal images annually. Diabetic retinopathy can now be readily identified with existing deep learning AI algorithms. Currently, there are two USDA approved algorithms with impressive AUC values and high sensitivity and specificity for detecting vision-threatening disease. The use of AI will be incorporated into the future directions of this project. I'd like to end by highlighting the goals of REACH-DR. By establishing a DR screening program, we would be able to identify eyes at risk for losing sight, directly benefiting individuals at risk of losing vision due to diabetes. An additional benefit will be the promotion of awareness for the need for eye evaluations, which will significantly improve the overall level of eye care and reduce the risk of DR-related vision loss in people with diabetes. The ultimate aim of this project is to set the framework for the implementation of a national program in the Philippines with a countrywide benefit. This will be carried out based on appropriate information in order to make it sustainable for the Philippines. In these final slides, I'd like to touch briefly on a topic that has the potential to change the manner we evaluate and follow our patients. Artificial intelligence and deep learning algorithms are expanding the horizon of diabetes care. Two particularly exciting developments include the use of predictive biomarkers for retinal disease and deep machine learning for automated retinal image analysis. On September 21, 2020, the Philippine Eye Research Institute, in collaboration with the Queen's University in Belfast, successfully deployed a validated AI algorithm for diabetic retinopathy screening, marking the first use of AI in ophthalmology in the Philippines. This is a significant milestone in Philippine ophthalmology and a step towards establishing an inclusive program for diabetic retinopathy screening that has the potential to eliminate diabetes-related blindness. We will be presenting our results on the use of AI in the second quarter of 2022. Let me end by saying that our expectations will change. Technology will allow us to think in ways not previously possible. Thank you, everyone. I'd like to thank the REACH-DR members who have significantly contributed to this work. Lizzie Aquino, Claude Salva, Lilibet Manganib, Drs. Resival Salongkay, Glenn Alog, Eileen Saunar, and Kay Lokay, and Professor Tunde Peto of Queen's University, and Professor Lloyd Aiello of Harvard Medical School. Thank you, everyone, for listening.
Thank you very much, Dr. Silva. We now call on our second speaker, Dr. Charles Yu.
Jenny can share our slides. Thank you for the invitation to join this virtual reception for the Newton projects. And my role is to give an overview and my study coordinator will give the technical details, and then I will come back for some concluding remarks. We were part of the second round of the Newton Agham Fund call for proposals that concentrated on infectious diseases. And the output from this project has actually gone around the world, and it's really timely that it comes back to the Newton Fund and our partners to have the final results to be shared as widely as possible, as it has done through its numerous outputs. So the title of the project was Impact Assessment of Diagnostic Tools and Algorithm for the Multi-Drug Resistant TB and Drug Sensitive TB. We call fondly the TB Fit project. The overview of the project was it was a 3-year-long project, but it continues up to today as a phase 2, as it was continued by the Department of Science and Technology. It's a collaboration between the De La Salle Medical and Health Sciences Institute and the oldest tropical medicine school in the world, the Liverpool School of Tropical Medicine. The recipients was Professor Bertie Squire from the LSTM and yours truly for De La Salle. These were more or less what was expected. We wanted to equip the Filipino researcher and in particular stakeholders, particularly the National TB Program, with a modeling approach that we could use to impact new diagnostic tools and algorithms for both multi-drug resistant TB and drug-sensitive TB, first in the province of Cavite and then expanding beyond it. It involved the development of the virtual model, analysis of diagnostic strategies, and building local model capacity. And this was very timely because at that time, the NTP was planning to replace the many years old AFB smear with another diagnostic tool, which was the Gene Expert. Next slide, please. So let me explain very quickly that the model was actually adapted from a software developed by the Lanner company using the Witness program, and it's called the Virtual Implementation Model. And it was actually applied not in health in the beginning. A company, a bank, actually wanted to find a way to reduce the queuing in the bank premises, and actually they used this Witness model to actually make more efficient and to reduce the waiting time of customers. Now, applying that in health, next slide. Our partners in the Liverpool School of Tropical Medicine, headed by modeler Professor Ivor Langley, actually pioneered this model and applied it in developing countries, particularly Tanzania. And this is one of the products that came out. This is the early model that was actually published in 2012. Next slide. So what is the virtual implementation model? Well, in a nutshell, it's a detailed patient pathway that takes into account the different or complex interactions that affects outcomes, bottlenecks, and limit from the time a patient seeks consult to the time he is diagnosed, treated, or dies. It's visual, it's flexible, it is output rich, it is very powerful, and yet it is very comprehensive. Next slide. It cannot do is it cannot tell for certainty the future with 100% predictive. The future is molded by unpredictable events, as the COVID has actually shown us. Models seek to simplify a very complex world, and comparisons are more useful than precise point estimates. It can also make it easier for decisions to be made, particularly at the highest levels in terms of policy, because decision-making is a political process. And the models can be used to bring evidence into the process and making it simpler to understand and where assumptions are made. Next slide. So what it can do is it can provide a better and more common understanding of current and potential future pathways through visualization. It can compare options by projecting the patient's and health system evidence over extended timeframes, for example, over a 5 to 10-year period. They can apply the evidence from one context to the project impacts on other contexts or other scenarios. It can estimate patient and health system costs if we scale up that diagnostic. And we can assess incremental cost effectiveness of the scale up. It provides critical data used to provide routine reports as well as prospective data collection and publications. And it is part of this pioneering work done by Bertie Squire, who was our partner, which is called the Impact Assessment Framework that is divided into 5 layers, which basically looks at equity. Who will benefit from the new tool and why? Particularly focusing on the marginalized and the poorest. Next slide. At this point in time, let me turn you over to Armen Jenny Barameda. One of the outputs of our project is to build sustainability as well as to transfer technology so that modeling could be done by our own stakeholders. And Jenny is a living evidence of how we transfer that technology so that they can do and apply and create this model locally and for the DOH and for other partners. Jenny, please take over.
Okay, thank you very much, Dr. Charles Yu, for that elaborate introduction about how the TVFIT project and its roots, and as a living proof of the other part of the project, which is to actually give some insights on how our 3-year project has bear fruit. So now, just to iterate, the TBFIT 3 project objectives are mostly first to develop a computer model for patient pathways in TB and MDR-TB diagnosis in the Philippines by collating patient and health systems data firstly from Cavite province and build sustainability approach in the modeling so Filipino policymakers can have access to the approach to develop a strategy from Cavite first, then for all provinces in the Philippines. As what has been mentioned earlier, way back in 2016, the current diagnostic algorithm, that is when your patients arrive in a health center for TB diagnosis, is the AFB smear, or commonly termed as your direct sputum smear microscopy. However, at the time, DOH has now this gene expert that they would like to be deployed strategically. Thus, our project also helped out our own DOH to assess the following strategies. So first is to change the routine standard microscopy with LED fluorescence microscopy with higher sensitivity, or to replace microscopy by the gene expert MTB-RIF and target, or for the third and subsequent strategies, so you target expert to smear negative cases or with X-ray indicative of TB as well as being smear negative. You also make your X-ray as a triage test before expert, so that's another strategy. Then the final strategy was a point of care test. So your POC tests are like your coffee machine size test that can be useful for, let's say, far-flung areas or in areas with limited testing capacity, which does not necessitate to use the whole gene expert apparatus itself. Wherever gene expert is used, we have 2 subcategories of different cartridges available. So these are standard and ultra cartridge, which has a higher sensitivity but lower specificity. Now, for some key data inputs over the course of the project, we mapped out the patient journey towards different points in TB diagnostics and TB treatment. There are many steps and stops along in the patient journey. This framework was also ultimately used to map out all of the possibilities where the patients can go, which led to this humongous patient pathway modeling. We pioneered it together with our LSTM partners using the Lanner software called Witness. We employ this into this huge simulator of TB diagnostics, predicting many outcomes such as patient yield, diagnostic accuracies of these new tools, patient volumes in different TB types of patients like DS and MDR, process times because some take a long time, yung turnaround of your results, patient times which we have primarily collected with actual patients in a time dynamic data gathering. Also, since there are many stops between patient diagnostics, so there are many points to which loss to follow-ups are considered. And because of this tedious process of getting patients diagnosed with other, so meron pa rin other neglected factors na hindi masyadong tinitignan with TB diagnostics, which we will later be discussing. For some sites modeled, so firstly, we chose your provincial health office in the Cavite, because we're in tie-up with DOH and TP. They chose these representative sites for primary data gathering. So some cities and municipalities in Cavite for DOT sites and also some MDR sites. And as we go along with our modeling results and upon sharing this with our various stakeholders, so they have recommended that we expand our data collection. Firstly, in Davao City, because of different circumstances like diagnostic committees in clinically diagnosed patients. Bulacan Province, because as per DOH, they would also like to have some insights on challenging provinces. And then upon synthesizing the three results of Cavite, Davao, and Bulacan, DOH chose 6 representative Philippine regions for the modeling approach to be applied. For some modeling results, similarly to what LSTM has done in their previous studies in Africa, we have been thorough in explaining to our stakeholders the results of the modeling. Of a particular interest, which I think our previous presenter also has mentioned, is health economic concept for called cost effectiveness analysis. So in cost effectiveness analysis, we have this cost effectiveness graph. So either your x-axis could have appropriate number of TB cases diagnosed or placed in appropriate treatment, or they can be also disease averted. And in your y-axis, we have your additional costs for over a certain period of time. In this case, we considered 10 years of predictive outcome modeling. So we can see na in cost effectiveness analysis rin, we usually put an indicator called your willingness to pay threshold. So that's around 1 to 3 times the country GDP. So anything that falls below the willingness to pay threshold, this black line here, is cost effective. And anything that goes beyond or on the left side is considered not cost effective. So it's up to the stakeholders, let's say our DOH, to choose which diagnostic algorithm can be best implemented in Cavite province given their resources and their actual goals in TB elimination. So other results include your some diagnostic yield of your correctly diagnosed TB patients, or your number of cases or MDR TB cases that are added, and incremental cost for patient and health systems alike. Generally, if you're gonna implement new diagnostic tools, then your patient costs will be lessened as evidenced by the graph here. So yung gray bars are actually patient costs, because it would be requiring less patient trips. So yun yung main cause why patient costs have gone lower. So similarly, now in our modeling results, before actually having these general graphs and figures, along the way, we have developed several sub-studies with regards to some modeling inputs, including the use of gene expert and the role of expert panel in diagnosing clinically diagnosed of smear negative cases. Because at the time, this is a missing variable in our modeling. So we required several data reviews for us to have a concrete assumption for how much of, or what is the rate of this clinical diagnosing for smear negative cases. While in patient cost survey, so we have this WHO costing tool, which we use to gather patient costs in Cavite sites. Ultimately, some recommendations for patient cost survey results in our paper was also used to revise the overall WHO costing tool. So some key impacts of our TB-FIT study the gene expert rollout projections see an increase of bacteriologically confirmed cases with these diagnostic tools, a likely decrease in clinically diagnosed because we now use our highly accurate diagnostic tools, which eliminates physician judgment, and a substantial increase in MDR cases. Consequently, your gene expert replacing microscopy is considered a cost-effective approach. However, policymakers should be wary of taking a one-size-fits-all approach, meaning gene expert could be likely be implemented in cases with high TB cases, but for example, in far-flung areas such as in islands, do you really need to put a gene expert machine or would it be more costly? So DOH has taken this kind of train of thought very to their hearts in implementing new diagnostic algorithms. Like what I've said earlier, yung cost survey findings were used to improve the existing cost survey costing tool of WHO. Lastly, Department of Health NTP utilized the insights gathered from the results through across different core levels of the NTP and in their respective regions. To quote, primary feedback from our training sessions with DOH and their representatives, they have implied that TB-FIT is NTP's first subnational modeling exercise. Unlike TB models, which focuses at the country level, our TB-FIT model can be applied at the facility, province, or regional level. So that's a subnational. Then through the TB-FIT project, not only did I develop my modeling knowledge, but also my new skills in new technology, in particular using Lanner's Witness software. In terms of the dissemination of results, like Dr. Yu has mentioned earlier, we have managed to partner up with with other project teams and other stakeholders, and we have presented to various forums locally, internationally, and even in the regional level, and which includes the union in APSR in Australia, various PhilCat sessions yearly, DOST. So it's not just limited to the medical and health sciences, but the sciences in general. Also in the APRC regional convention here in Manila last before pandemic. And through the years, we have developed a partnership between not just LSTM, Liverpool School of Tropical Medicine, but also with NTP. So in terms of the capacity building, our main activity was were three virtual implementation modeling training workshops in the span of 3 years. And our delegates, depending on the data that we have currently, we invited Cavite local government health unit workers, provincial health officers. We also invited Region 4, Region 3, even Davao City, and some regional stakeholders. But our work did not end there. So given the great reception of our Philippine DOH towards the results of TB-FIT1 project, it became possible for us to give birth to another shift of focus for reaching the NTB goals. Because it's not just diagnosing your cases correctly, there are still missing cases out there that are not reached by setting up accurate diagnostics alone. We have this quick overview of where we are as a project team with LSTM and other stakeholders and how we are going by the DOH recommendation in expanding our research. Take for instance, in the eyes of the truth, so these are Filipinos with TB. Now, then we add this group of people to represent Filipinos being tested for TB. Now, who is currently treated? So these ones highlighted in green are just the ones that are treated in reality. In terms of how can more accurate diagnostics like Gene Expert can help, this has answered by the results of our TB-FIT1 project, which is, if you're gonna look at this portion, so Gene Expert actually reduces false diagnosis. But where do we find these missing cases that we have mentioned earlier? So we are not testing enough. In the eyes of truth, we do not know where these missing cases can be found. All that we know is that they are out there in different target groups and settings. Suppose we find them human error cannot be like ultimately prevented by this, because some that we are actually finding cannot be also through TB cases. So we are not interested in this group of people with no disease, and that we are eager to know how can we find these groups of patients. This gave birth to TB Fit 2 modeling of active case finding strategies. So we would just like to give a brief overview. Active case finding strategy is required to identify and treat TB cases, so those missing ones, especially those in the community, as rapidly as possible. Because active case finding is highly dependent on resource availability, so it's important for us to optimize the implementation of active case finding in a most cost-efficient way. To give an overview, our TVP2 project continued for another 3 years, and actually this year is its last. So we modeled active case finding strategies in 5 provinces of Region 3 as identified with DOH. We determined costs and yield of different TB diagnostic strategies simulated in a 10-year period. We aim to draft guidelines on scaling up of new diagnostic strategies considering cost-effectiveness analysis results similar with TBFIT 1. And through this, we continue to conduct our workshops and exercises to spark interest in country-based TB modeling, not just in TB, but possibly in other disease areas. So what makes active case finding modeling essential? First, it provides an understanding of how different populations would be affected differently and which to prioritize, which could be more appropriate in a target setting. Does active case finding seem feasible for health centers and departments? Do we prioritize like testing a lot of patients, having a broad spectrum tool, or focus more on confirmatory and be more stringent in screening process? Secondly, it allows comparison of ACF implementation with alternative interventions. So are we really sure that if we reach out our target groups that we may find the cases that we are potentially missing? So the third one is our modeling allows for an economic evaluation from both a programmatic and societal perspective. So our health ministry is able to align the results of our project to their implementation practices. And lastly, a versatile model is considered or important considering challenges in case finding strategies during COVID-19 pandemic, since symptoms are similar for TB and COVID. So how are we able to manage these kinds of nuances? Now for the future of TB Fit, I'll turn this back to Dr. Charles Yu.
So last 2 slides really summarizes what we hope to do in the future. The TB Fit 1 actually happened before the pandemic, so we were very lucky. But TB Fit 2, which is funded by the GIA from the OST, was caught up in the pandemic. So what we have done is we have successfully proven over these past few years, now running 5, that we have a better understanding of the picture of TB diagnosis and providing evidence for the deployment of these new technologies. We've evaluated the benefits that can be achieved by the application list. We have built the modeling capacity within our institution, and more importantly, with the DOH stakeholders and those that are working in the field. And we are now in the process of evaluating active case findings. Of course, great challenge because of the lockdowns. Next. Where do we go next? We need to continue to utilize the virtual health system modeling for TB. We'd like to work towards applying the methodologies to a broader health areas in the Philippines. And we are actually eager to use these models even in the fight against and in the deployment of the various weapons against COVID. What immeasurable benefit from this Newton Agham grant is the eternal friendship and partnership and professionalism that has been exhibited from both sides, and which has actually, I think, been a learning for us. I am a 32-year veteran of the TB research world, and I learned a lot with the way from the crafting of the proposal to its presentations. I think this is one of the things that we can be proud of when this project was actually finished, and it continues to this day. So thank you very much for the opportunity to share our results. And these are all our partners, too numerous to count, from the DOST side, PCHRD, to the National TB Program, particularly the program manager, Dr. Garfield, Celine, Donna, and the others, and across the regions in the province, in Davao, in Bulacan, and in the different regions. In fact, the entire DOH program managers and regional coordinators, and of course, our partners, Professor Bertie Squire. It has been my dream to work with him on a project like this, and Dr. Ivor Langley, Iwan Tomeni, Laura Rosu, who continues to work, and I'm very proud of the team, particularly Jenny's presentation, Naida, Vicky, AC, Vic Mendoza, Jovi Abong, Maris Tonkin, and many others. Maraming pong salamat.
Thank you very much, Dr. Charles. Now for last speaker, I'd like to call on Dr. Tipi Tanchanco.
Hi, everyone. I hope we're all doing well. Let me begin by thanking the organizers of the Newton Agham Fund reception through Mr. Danny Gonzalo for inviting me and allowing us to share our story with you. So the title of our project is Mathematical Modeling for Universal Healthcare. I head the Ateneo Center for Research and Innovation, or ACRI, which is the research unit of the Ateneo School of Medicine and Public Health. We have 3 flagship research areas, namely health systems governance, mental health science and neurodevelopmental disabilities, biotechnology and environmental health, and we also have an innovation arm. The research unit is relatively new as we were only commissioned by the School of Medicine and Public Health in 2017. And I was tasked for this talk to talk about how our project is and its contribution to sustainable development. And as a research unit in a medical and academic institution, we see our role in contributing to sustainable development goals, which aim to ensure healthy lives and promote well-being for all at all ages. And we do this through timely and relevant research, innovations, engagement, and partnership with local and international institutions. The Universal Healthcare Act was signed into law last February 2019, and the UHC means that all Filipinos have equitable access to quality and affordable healthcare goods and services when and where they need it, while being protected against financial hardship. The law recognizes that the whole of system, whole of government, whole of society, people-centered approach is necessary for the implementation of the law to succeed. This will necessitate the availability of data and the processing of this data to aid with policy and legislation. And this will need expertise of professionals from diverse fields to study this data and process it to improve how healthcare is delivered in the country. And because of the nature of our academic institution, as an academic institution, as Filipino and as Jesuit, we feel compelled to participate in its implementation. When we heard about the call for the Newton Fund Researcher Links Workshop, our team, composed of Dr. Manuel Dayrit, Mr. Vincent Pepito, Dr. Madeline Ong, and myself, decided to propose a workshop for health researchers from both academe, government, healthcare, private sector, and international institutions. To this end, we leveraged our connections in the UK in preparing for our workshop proposal. We envisioned the proposed workshop to improve health governance in the context of universal healthcare through mathematical modeling and building partnerships with different institutions from all over the country, as we believe that good governance is hinged on good data, evidence-based policies, and multidisciplinary collaboration. We wanted to make an impact through collaborative evidence-based policies to aid the implementation of the universal healthcare law in the Philippines. As we implement universal healthcare, it's important to foresee demand for healthcare services, as we've heard earlier, like how many vaccines for measles or drugs for HIV and TB, as we heard earlier as well, should be purchased for the coming year. More recently, how many hospital beds and ICU facilities should be prepared for a projected surge in COVID-19 cases. Mathematical models allow us to answer questions like these. And this is the reason why we organized a training in mathematical modeling with partners from Public Health England, led by the eminent mathematical modeler and author Dr. Emilia Vinicki. And in 2019, we were awarded the grant funded by the UK Department of Business, Energy and Industrial Strategy and the Department of Science and Technology, Philippine Council for Health Research and Development, which was delivered by the British Council. We were supposed to run the face-to-face workshop on August 2020 with partners from the UK flying to the Philippines, but the COVID-19 pandemic happened, which led us to implement a fully online workshop instead. Another pivot that we had to do is to subsume the annual Public Health England London School of Hygiene and Tropical Medicine short course on the Introduction to Infectious Disease Modeling, which was already been running for 20 years in London, to our proposed workshop. Luckily, our UK partner, Dr. Vinicki, also heads the said annual workshop, and it was for this reason that our final posters included the logo of LSHTM. We issued a call for participants from April, May 1 of this year through our social media pages of the British Council and formal networks of PCHRD. And we had more than 90 applicants from all over the Philippines for just 30 slots. So it was for this reason that we implemented a stringent selection process by assessing the applicants' work and educational experience and projected impact of their participation to their communities and fields of practice. We also ensured that there will be sufficient representation from all throughout the Philippines. This figure shows the distribution of respondents according to the location of their institutional affiliation. 14 of the 30 participants came from Metro Manila, 7 came from Luzon, 4 came from the Visayas, and 6 came from Mindanao. Our workshop was participated by qualified early career researchers of different backgrounds. Around 30% of participants were female, 40% of our participants were medical doctors, and another one is a doctor of veterinary medicine, whom we accepted as she intends to use what she would learn in our fight against African swine fever and other zoonoses. The other participants had mathematical, computing, or engineering backgrounds, of which 2 have PhDs and most have master's degrees. We had 4 participants from various bureaus and units of the Department of Health, another one from PhilHealth, 5 from private research firms and NGOs, and the rest were from public and private academic institutions. Finally, the fully online workshop ran from June 11 to 29 of 2021. It kicked off on June 11 with a welcome session, introduction, and research dissemination activity by the participants, and a brief introduction to the Philippine health system given by Dr. Manuel Dayrit. From June 14 to 25, the PHE LSHTM short course, Introduction to Infectious Disease Modeling, ran. This consisted of synchronous lectures, discussions of published literature, modeling exercises, and social activities. Over 80 participants from different nationalities and backgrounds participated in the PHE LSHTM short course. Eminent mathematical modelers and epidemiologists at the forefront of COVID-19 modeling in the UK were invited in the short course. They included Dr. Paul Fine, Dr. Adam Kurchaski, Dr. Mark Jitt, who was part of our research, and Dr. Keisha Prem. Our very own Dr. Dayrit, former Secretary of Health and former Dean of ASMPH, also gave a lecture on applying mathematical models to health services research. Despite the time zone difference, the participants from the Philippines attended the short course religiously with very high attendance rates throughout the course. The workshop was very timely as we were in the midst of the pandemic. After the 2-week PHE LSHTM workshop, the participants received lectures on COVID-19 modeling. and Policy in the Philippines, given by Dr. Elvi Tuprio, and Modeling for UHC, given by Dr. Regina Estuar. Both resource persons are faculty from the Ateneo and are advisors to the government's COVID-19 response. And on June 29, we had a webinar on translating mathematical models to policy, presided by Dr. Manuel De Rit, Dr. Beverly Ho of the DOH, Dr. Mark Jit, our co-investigator, Dr. Rina Estuar, and Dr. Elvi Tuprio as panelists. After the 2-hour webinar, the participants presented the research capsule proposals, applying what they have learned in proposals that can be submitted for possible finding. We then closed the 13-day workshop with a short closing ceremony. So what did the participants say about the workshop? The course was well received, as seen by some of the comments from participants listed here. We wanted to review the impact of the workshop and see how participants were doing after going through the workshop and how they were using their new knowledge. And these were some of the things that we found out. Our participant from the PhilHealth, Dr. Vincent Malbas, has disseminated what he has learned from the workshop to his community at PhilHealth, as well as his alma mater, the University of the Philippines College of Medicine, in a scientific symposium with over 1,000 attendees. Our participant from Caraga State University, Mr. Jeriel Rendeza, has disseminated what he learned from the workshop to his students and colleagues. Family Health International is an international NGO, and our participant from FHI, Dr. Jeremiah Calderon, has recently received funding to conduct research on tuberculosis modeling in Tarlac Province. One of our participants from the Provincial Health Office of Northern Samar used what he has learned from the workshop to sponsor the setting up of the province's epidemiological and surveillance unit. Two of our participants, one from the provincial government of South Cotabato, Mr. John Limuel Dalisay, and another from the University of the Philippines, Mindanao, Mr. Zaithon Lachica, have recently formalized their collaboration with a memorandum of agreement so that Mr. Dalisay can send their COVID-19 data to UP Mindanao, while the latter will help with data management, analysis, and COVID-19 projections for their province. And our faculty, Mr. Vincent Pepito, has recently been involved in mentoring Mr. Zylon Lachica of UP Mindanao in survival analysis, and has encouraged the latter to apply for further studies in epidemiology, biostatistics, and modeling in the UK. So our grant is still running, and we intend to check in with our participants in 2 months' time as we continue to engage and collaborate with them in their different mathematical modeling aspirations, as we pay forward the generosity of the UK Department of Business, Energy and Industrial Strategy, the British Council, the Newton Agham Program, and the DOS TPCHRD. We thank you very much for your continued support for our endeavor and our vision for evidence-based policy making in the Philippines. Have a good day.
Thank you, Dr. Dippy. At this point, we are opening the floor for any questions from the audience for our 3 speakers. If you have any questions, you can either pop them on the chat or raise your hand.
Hindi atin.
Okay. Considering that we don't have any questions raised, we'd like to take this opportunity to thank our 3 speakers. Thank you,
Please,
Dr. Silva.
please, can I?
Yes. Yes, go ahead, Dr. Charles.
Wait, can I lower your volume? As you can see that we have developed the capacity for mathematical modelers to be trained here locally, and we're still partnering with the DOH NTP program. But me as their, I guess, their boss and as vice chancellor, we would be interested in pursuing, they are interested in pursuing more advanced courses, and so that we can be able to absorb them permanently in our own institution. So they, in a way, they were trained for 3 years by the professors in Liverpool. And so they have the capacity. It's like the equivalent of 1 year or more diploma course. But it would be good for continuity. And I think Jimmy Montoya is also in the audience, that we're looking for training to, there are not too many mathematical modelers in health in our country. And HTA is something that we are in the very beginning of, I mean, we've been training HTA since I can remember, but really we are aging as experts in that. So I think a new generation of mathematical modelers, which is, as an example, the presenters here, except me, should be, because that's the wave of the future. It's really looking at cost effectiveness analysis and making it understandable to decision makers in terms of being fed the evidence, making them understand what ICER is. And I had a clinical epi master's course, but I only really fully understood it when with this project really went into full bloom, and we had to explain it to many people from all over the world. So it would be nice if the British Council, the UK, could continue the effort already that has been started. And I am very happy Ateneo is actually offering a short course in mathematical modeling together with the rival of LSTM, the London School, who I also know as someone representing them. But in the light of the COVID, this is one big home for all of us. And I think the good thing that came out of the lockdown, if you can say, is the world has become closer with Zoom and with the online training. Imagine how we could do the online training, the mathematical modeling for phase 2 of our project when our stakeholders are in complete lockdown in region 3. So this is something that we all learn from, but it would be nice if the different sponsors and institutions would further this. Sayang, if I may say that Tagalog word, sayang kung all the talent that was and parang training that was developed will not be utilized for the betterment of the world and our country. It's actually not a question, but it's a challenge to our partners. I can say this because I'm in retirement mode.
Thank you very much for the call to action, Dr. Yu. Do we have any other reflections, feedback, or questions?
May I just comment on what was raised by
Yes,
Dr. Yu?
go ahead, Dr. Montoya.
Yeah, I think I agree that health technology assessment is a new area of concern and emphasis, and we are willing to support people who will train on this. In fact, we are in the process of having local courses for HTA, and I welcome Ateneo, of course, to also be part of that consortium. We're creating a network of institutions that offer courses on different aspects of health technology assessment, but we are also maybe going to partner with the British Council and with other appropriate English organizations in order to make this happen. Because I know that the British Council also has a wide network and we can probably work with them. So maybe this is a good start for what we would hope for as far as health technology assessment is concerned. Thank you. And I'd like to commend all of the projects. I think they're going to be very useful programmatic-wise. The diabetic retinopathy screening by Dr. Paulo Silva, the TB Fit of Dr. Yu, and the Dr. Tanchanko's project as well on universal healthcare, I think are all very relevant, and we're very happy with the outcome, and hopefully this will just be the start of more collaborations in the future. Thank you very much.
Thank you very much, Dr. Montoya. Are there others who want to put a comment before we end this breakout session? If there are none, then thank you very much again to our three speakers and to Dr. Montoya for his comment. We'd like to call on our attendees for this breakout room. If you could turn on your camera, we'll take one more group photo before we go back to the main room. Okay, so I will be taking the photo. Please hold.
I'll assist you, Liz. I can take the photo.
Okay, thank you, Henry.
Okay, 1, 2, 3. All right, one more. One, 2, and 3. All right.
Thank you again, everyone, for joining this breakout room this afternoon. One tip from us is please don't click the leave room button at the bottom of your screens. Instead, you can click a red or blue button that says leave room, but don't leave the call. So yeah, we'll see you in the main breakout room then. Thank you very much, everyone.